We're going to talk a little bit about malaria. You've already had some talks by Joanne Fenn on parasites. So this is one of the great parasites of the world, and an important part of the world. If we look at this list of diseases, of infectious diseases in the world, about 1/5 of all deaths in the world now are still due to infections. And if you look at this list, you can see that there's some well-known things. So pneumonia, HIV/AIDS, gastroenteritis, tuberculosis, and malaria then in the year 2002 was accounted for a little over 1.25 million deaths in the world. Most of those are young children or old people, but a very serious infectious disease. If you look down here at the bottom, by 2013, there's still a lot of cases. So back in 2002, there were 600 million cases per year. Now we're down to 207 million cases per year. That's pretty good. And the death rate has gone from 1.27 down to 627,000 deaths per year. So we're making some progress. This is one of the first times we've ever really made progress in decreasing the prevalence of malaria in the world. You probably can't see this very well, but this is from 2010, looking at the countries where malaria takes place. There are 99 countries in the world that have an endemic focus of malaria. Of those, 3 of them then account for half of the malaria in the world. And if you can't read those 3 are Nigeria, the Democratic Republic of the Congo, and Burkina Faso. So all in Western Africa. If you look then, there are 14 countries that make up 80%. So if we go up to 80%, 14 countries account for that, and Ghana is the last one where we do a lot of work in that group of 14. If you look at 98% of malaria, it occurs in approximately 35 out of those 99 countries. So there are a number of countries that have endemic focus that have made fantastic improvement in malaria. There are still some really serious countries up here where malaria is still a very serious problem. And one of those is Ghana. If you look at Ghana in 2011, outpatient visits, 40% of their outpatient visits to clinics were due to malaria. If you look at hospital admissions, a little over 1/3 of all hospital admissions are for malaria. If you look at deaths, 18% of the deaths. If you look at percent of deaths in kids under 5, 29% of those are from malaria. Now you just think what would happen at primary children's. If 1/3 of all of our deaths at primary children's were from a single disease, we would be so down on that. We would do everything possible to try and prevent that kind of mortality. And then the place where we have really made progress is in the case fatality. So this, of every 100 people, 100 kids under 5 that get malaria, only 1.2 of them are now dying. Now that's bad. If 1 out of 100 kids died from malaria, that's bad. But it used to be 4 out of 100. It used to be 1 out of 25 kids died from malaria. So we've made good progress. If you look at who's dying, it's kids like this little kid, these little kids. Those are the people. This is a village we work in Ghana. The kids there are really the people at risk for dying from malaria. So let's go talk a little bit about the history of malaria. So we've had descriptions of malaria both in China and Europe for a long time. The Greeks used to have a disease that they called periodic fevers and splenomegaly. That meant that these fevers came back every 2 or 3 days, and these people developed big spleens. We think that was malaria. They found that they could decrease the risk of that disease by draining swamps. They thought the swamps caused malaria. It wasn't the swamps. It was the mosquitoes that were in the swamps that caused malaria. And then in the 1700s, people from Europe that ended up in Peru found that people in Peru used to chew the bark of this quina tree, and they used it for whenever they got fever. Well, it wasn't very good for most fevers, but it treated malaria. So this was a treatment of malaria. And eventually, in the mid-1800s, we found out that was quinine. So almost all the patent medicines of the 1800s had quinine in them. We even put quinine in soda water, thinking that it would make us healthier. Well, it probably doesn't make us healthier, but it does treat malaria. So many of the explorers that went to Africa carried this bark with them, and when they got malaria in Africa, they would treat themselves with the bark of this tree. Well, we eventually were able to produce that and find better medicines than chewing tree bark. So in 1891 then, a man by the name of Ross discovered that, or proved that, malaria was spread by mosquitoes. So now we know about why the Greeks drained their swamps and the incidence went down. If mosquitoes are carrying this and we can decrease the mosquito population, then we can decrease the prevalence of this disease. So in 1902, Ross got the Nobel Prize for describing the malaria life cycle, and we'll go over that in just a minute. But even then, we didn't know where malaria went. So when after the mosquito bites you, you may have 1 to 4 weeks before you get sick, or in some cases a number of months before you get sick. We didn't know where the malaria organism went until 1948, when they discovered that it hid out in the liver. So there's a liver phase of this life cycle that Ross didn't discover. So in the United States, we had malaria all across the United States, from the East Coast clear to the Rocky Mountains, and a focus of malaria in Southern California. With time, we were able to decrease that amount of malaria down to just the southern part of the United States. And in 1948, we eradicated malaria completely from the U.S. And we did it by using a medicine called chloroquine that was better than quinine. We used it by draining swamps like the Greeks did. And we used it by spraying DDT in our homes and in places to get rid of mosquitoes. And we did this. In 2 years' time, we eradicated malaria from the United States. Europe did the same thing. Southern Brazil did the same thing. So the World Health Organization said, hey, if they can do it, why can't we do it throughout the whole world? So they started an eradication program in 1955, and they did the same things. They used DDT to kill mosquitoes, they drained swamps, and if they couldn't drain them, they covered the top with oil, and they used chloroquine to treat and prevent malaria. By 1976, that was declared an absolute failure, and it failed for all 3 reasons. Number one is the malaria became more resistant to chloroquine, so it didn't work as well. We found that DDT not only killed mosquitoes, but it killed a lot of other animals up the chains of the food chain, and so we couldn't really use DDT very safely. And putting oil over water also destroyed a lot of plant life. So in 1976, they stopped the program. By the mid-90s, malaria and all mosquito-borne diseases had become more prevalent because the mosquito population of the world had increased so much. So that's kind of the history of malaria. If we look at the classification, it belongs to the kingdom Protista. It belongs to the class Sporozoa. The Sporozoa class in this kingdom is the class that has sexual reproduction. So even these one-celled organisms are able to, at times, produce by combining DNA. And so malaria is one of those. Malaria is a sporozoa that has a sexual reproduction phase. The genus is Plasmodium, and the species for humans is Falciparum, Vivax, Ovalian malariae. So we have 4 species of malaria that are the human malarias. Now there are a whole bunch of other malarias that infect monkeys and rodents and birds and reptiles. All of them have their own species, and usually there isn't cross transfer from other animals to us. Recently there's a 5th malaria species of monkeys that we now see more commonly in humans. But that's quite unusual. So we're going to just cover these 4 species, and that's what we'll talk about today. Now, in parasites, the definitive host is the host where sexual reproduction takes place, and the intermediate host has reproduction, but it's more just cell division, not sexual reproduction. And the definitive host for malaria is the mosquito. So that's where the sexual reproduction takes place. All of the reproduction in humans is just from plain cell division. So here's the life cycle. This is really more complicated than you ever want to believe, but there are 3 main areas: there and here's the mosquito. So the mosquito picks up the gametocytes. So by this time there's a male and a female gametocyte. The mosquito picks those up. They combine to form an oocyst and develop then into sporozoa that migrate to the mouth organisms of the mosquito. And when the mosquito then bites a new host, it can transfer these sporozoa into the human being. Within 30 minutes, those sporozoa all are transferred from the skin to the bloodstream to the liver. And there they can either start multiplying immediately and produce a whole group of ring organisms, or they can sit there for a number of months, inactive, not causing any trouble. During this time, there are no symptoms. Yes?
So do they use the hepatic portal system in order to get into the liver from the bloodstream?
The question is, do they use the hepatic portal system? They're in the total bloodstream. So part of them, as they move through the liver, they attach to the liver, and then they invade the liver cell. So they then can sit there, or they can start dividing immediately. The fastest they can go from the liver to this is 7 days. So the incubation time then is the very fastest can be 7 days after the mosquito bite. The average is 2 weeks, and usually within 4 weeks, the ones that start dividing right away have all matured to the point where they develop the ring forms and go into the red cell. Once they're in the red cell, then we begin to become symptomatic. So we have no symptoms at all while all of this is taking place in our liver. Once they invade the red cell, here's the little ring form that you can see in the red cell, and then it begins to mature and develop cytoplasm. Then it begins to divide and form new merozoites, and then it ruptures the red blood cell. The new merozoites then go into new red blood cells, and this cycle is repeated. For some reason that we don't understand yet, some of these merozoites, instead of forming trophozoites, develop into gametocytes and prepare themselves to be taken up by the mosquito to complete the life cycle. Now this system here synchronizes so that almost all of this happens together. And when it happens together, then we develop the acute symptoms of malaria. And then when it invades the new red blood cells, and while it's developing for about 48 to 72 hours, we become better again. The symptoms disappear. And then we develop the fever again when this happens a second time and a third time. That's where we get the periodic fever that we talked about that the Greeks described. All right, so let's talk about a patient then with falciparum malaria. So this is Plasmodium falciparum. This is the most important malaria that we study because 98% of all deaths are from this species of malaria. So this is a patient that we saw here at the VA hospital, a 52-year-old male. He had gone to Ghana, Africa. He'd not taken any medicine to prevent malaria like we're supposed to if we've never had malaria. He came back to Montana. About a week after he got home, he started having chills and fever and sweats, and he called his doctor and he said, I'm sick, and his doctor said, well, take this antibiotic, and didn't even see him. Within 3 or 4 days, he was found unconscious in his room, and they put him on an airplane and sent him to Salt Lake City. By the time he arrived here, we knew that he had been in Ghana, and we knew that the most likely thing that he had was malaria. So we looked at a blood smear, and you can actually see these organisms in the blood smear. We'll show you that. And 1/3, 30% of his blood had the malaria organism in it. Now, if you think about that, that means that when that matures, this next cycle then is going to destroy 1/3 of his red blood cells. He was in serious, serious condition. So we started him on medication. We treated him with an exchange transfusion a couple of times, and we thought that was a good thing, and it may have been, but with better medicine that we have now, we have found that exchange transfusions probably aren't that much of a help. But after his first exchange, his parasitemia went down to 10%. After the second time, it went down to 1%, and essentially his malaria had been treated. But the damage that it had caused was not treated. So what happened? He was still in a coma, so he still had cerebral malaria. It took him 2 weeks to get him out of that malaria coma. His respiratory system, his lungs were not working, so we had him on a respirator, and it took 3 weeks before we could wean him off his respirator. And then his kidneys failed. And he required dialysis for 6 weeks, and then his kidneys recovered. So why those 3 organ systems? We'll see in a minute what happens to the organ systems, but those 3 organ systems are more sensitive to lack of oxygen than some of the other systems of the body, and so they're the ones that are most damaged by a severe malaria like this man had. So let's talk about why this organism causes almost all of the deaths from malaria. And the number one thing is it can invade all stages of red blood cells. So you think of red blood cells are red blood cells, but for malaria, red blood cells are new red blood cells that have just been produced from the bone marrow, all red blood cells, or red blood cells at 90 days. At 90 days, most red blood cells then are senescent, and they're destroyed by the spleen. Falciparum malaria has the ability to invade all stages of red blood cells, the young ones, the regular ones, and the senescent ones. So the whole blood supply is open to invasion by malaria organisms. The second thing is, once the malaria gets into the blood cell, it starts to digest the hemoglobin that's in the blood cell. And that's what it uses as an energy source for it to grow and divide and mature and continue its life cycle. As it does that, it produces malaria proteins that migrate to the surface of the red blood cell. Now, one of the amazing things in life is that antigen, that malaria antigen on the surface of the red blood cell has a receptor site in our bodies. And that receptor site is in our small blood vessels, our capillary blood system, so that a red blood cell with an antigen on it can attach to our vascular system and absolutely plug up our vascular system. So that's why we think it causes the damage to the brain and the lungs and the kidney. If we destroy the blood cell, if we destroy the flow of the blood cell by all of these things clogging up our blood vessels, that's what really does the damage that results in our severe illness. Now, this same thing then can cause red cells to hook together and cause plugging up of blood vessels, or they can actually agglutinate together. So we think that's why this organism, so number one is it can inhabit all red blood cells, so you get a huge parasitemia. Number two is it can plug up the vascular system and damage our organs. So this is an artist's rendition of what Plasmodium falciparum looks like. You can see an uninfected red blood cell. You can see the ring form. You can see the merozoite ring form then begin to form cytoplasm and develop into a trophozoite. The trophozoite then begins to divide, and you get new merozoites that go back up and invade the red blood cells again. If we were to look at a smear of one of these, of someone with falciparum malaria, we would see ring forms, and occasionally we would see gametocytes, and we wouldn't see any of this. And the reason we wouldn't is because this stage of the infection is all hung up in our vascular system. So we don't get to see it. We don't get to see all these other stages because it's all hooked into our vascular system and living happily waiting to destroy our next red blood cell cycle. What we do see then is the ring forms before they start to attach to the vascular system, and we see the merozoa, or the gametocytes, which are waiting for a mosquito to pick them up so they can complete the life cycle. Now here we can see just a little better in what we really see. So frequently there are so many merozoites that we can see infection where 2 or 3 of them get into the same red blood cell. So this is a huge infection. Here are the gametocytes. These are called banana-shaped gametocytes. Even in these, if you look carefully, you can see that they are inside the red blood cell, and they just stretch out the red blood cell and continue to use the hemoglobin as a source of energy. Here's what they really look like under the microscope. So that's Plasmodium falciparum. Let's talk then a little bit about vivax and ovale. We're going to talk about them together because the two of them together really are so similar that it's easy to learn everything about one and know what's happening with the other. There is one major difference that we'll talk about a little later. So this was a 27-year-old female. She went to Kenya to help build schools. She took all of her medicine, preventive medicine, just like she was supposed to, while she was there and for 4 weeks later. So the medicine that we give doesn't work in the liver. So what we do is we keep them on it 4 weeks after, because if it breaks out of the liver into the red cells, then that medicine works. But it doesn't work in the liver. That's why these people are supposed to stay on their medicine for 4 weeks after they come back. She did that. 12 weeks later, so now she took her medicine for 4 weeks. Now we're 12 weeks out. She developed chills, fever, sweating, headaches and muscle aches. And she went to the emergency room and told the doctor, "I think I have malaria." And the doctor laughed at her and said, "You can't have malaria. Malaria should happen within the first 4 weeks." Well, he forgot about this kind of malaria. So in this kind of malaria, either Vivax or Ovale, the liver organism may not even divide for months or sometimes years. So it may sit there asymptomatic, no symptoms at all, and then break out and cause disease months or years later. In this lady, it was 3 months afterwards. What does this allow this organism to do? This allows this organism to go through a dry period or a winter period and then break out the next time there are mosquitoes available. So this is more off so you can see this in tropical countries, but if you look at temperate countries, this is the malaria that can wait from one winter to the next. And so you're more likely to see it in places like the United States. So anyway, the emergency doctor was smart enough that he ordered a smear, and the malaria smear showed 1% parasitemia, not 30%. And they noticed that the red blood cells were larger than the non-infected red cells. That's what happens in immature red cells, or we call those reticulocytes. So about 3% of our of our red blood cells can be new blood cells just released from the bone marrow. They're a little larger than usual, and it turns out that Vivax and Ovale have a very hard time getting into red blood cells after they've passed the reticulocyte phase. So that limits, so it would be very hard for one of these organisms to cause 30% parasitemia. Usually it's in the 1% area. So they noticed that. They noticed that there's a stippling of the red blood cells called Schiffner's dots in the red blood cells. We'll look at those. And then the final thing is, these organisms don't have the capability of attaching to our vascular system. So we see the whole gamut of their life cycle. We see the merozoites, we see the trophozoites, we see everything, their whole life cycle when we look under the microscope. So this then, patient can be treated with chloroquine on an outpatient basis, and then there is one single medicine that will kill the organisms that are left in the liver cells. So in this lady, she was treated with chloroquine. That got rid of her acute red blood cell phase, and then she was treated with a medicine called primaquine that killed these hypnozoites, or these sleeper cells that are in the liver that are left over. Otherwise, she could develop malaria again, another 3 or 4 months. So this is the artist's rendition of this organism. You can see again there are the ring forms. You can see the trophozoites. You can see this little stippling that we talked about in the red blood cell cytoplasm called Schiffner's dots that are seen with both Vivax and Ovale. And if we looked at the microscope, we could see all of these develop, all the development phases of this life cycle. And then notice that, remember the banana-shaped gametocytes? These then are amoeboid gametocytes that the mosquito takes up that complete the life cycle. So here you can see a little bit better. Here's a reticulocyte. You can see that this infected red blood cell is larger than the others, so we think it's a reticulocyte or a immature form of the red blood cells. A little harder to tell in some of these others. You can see, here we can see the trophozoite cytoplasm, and here we can see the schizont, where they're getting ready to break open and infect new red blood cells. and then the gametocyte, the amoeboid gametocyte. So the final species of Plasmodium is Plasmodium malariae. It's a fairly benign form of malaria. The best example of this was written up when there was a 74-year-old female born and lived in Greece her whole life. Greece also eradicated malaria in the 50s and 60s, so that we think this lady must have gotten malaria when she was a young girl and lived with it her whole life. She didn't ever recall acute chills, fever, or sweating. In 1995, however, she was found to have an enlarged spleen. And the doctors taking care of her said, "Oh, we think you have lymphoma." And they started her on chemotherapy for lymphoma. And then she developed fever and chills, and it was a cycle of every 72 hours she had fever and chills. Well, they did some antibody testing, found out she had antibody against Plasmodium malariae. They were not able to see it on the under the light microscope, but they were able to do some very fancy antigen tests that showed that this was Plasmodium malariae. She was treated with chloroquine, and her splenomegaly resolved, and she didn't have really lymphoma. So in this case, this lady probably lived with this fairly benign disease for years and years, and then after it was started on chemotherapy, it began to flare up and cause symptoms. Here's the blood stages of this. Again, the ring forms. You can see that the trophozoite in this stage is usually called a band formed, so it looks a little different than the trophozoite seen in the other three species. And again, you have amoeboid gametocytes. You can't tell really well here, but old senescent red blood cells. So this species cannot get into reticulocytes. It cannot get into healthy red blood cells. It gets into senescent red blood cells that are almost ready to be destroyed by the spleen. Sometimes those are a little smaller, and you might be able to see that a little bit here. This is infected red blood cell, a little smaller than those around. So this organism has a huge disadvantage. It really does not cause severe illness in humans. Let's see. Well, here's the band form of the trophozoite. Here's the schizonts ready to break open, and here's the gametocytes. So those are the four species. Let's compare them just a little bit. There's some other things that we ought to know about. So we've already talked about why falciparum may be most plentiful in the tropics, because it needs a constant, continuous mosquito population to maintain itself in the environment. Whereas vivax and ovale have this hypnozoite in the liver that allows them to live in a more tropical or a subtropical country. And then this malaria that has chronic continuous infection can live in the tropics or in the subtropics also. Now we mentioned that the malaria organism uses the hemoglobin of our red cells for its energy source. It turns out it has a harder time digesting hemoglobin if we have an abnormal hemoglobin. What it likes is regular old hemoglobin that's in every healthy person. But if you have a disease like sickle cell disease, or if you have an abnormal hemoglobin that's hemoglobin C, D, or E, or if you have a disease called thalassemia with an abnormal hemoglobin, or with one of these deficiencies in the hemoglobin, these then protect the person. So these may cause the person to be sick from these things, but it protects the person from malaria. So if you go to West Africa, like Ghana, approximately 15% of the population of West Ghana, of West Africa and Ghana, have sickle cell trait, and that means that a large population of their children have sickle cell disease. That's a serious disease. But with sickle cell trait, you're protected and you're more likely to live through an infection of malaria than if you had normal hemoglobin. And that's somewhat true with all of these others. So there's a host resistance pattern that's protected some people from malaria, and it's allowed the genes for these to become more prevalent in areas of the world where there is malaria. So the other thing, we talked about Vivax and Ovale as if they're exactly the same. There are some differences, but the major difference is a difference with regards to Duffy antigen. So Duffy antigen is an antigen that we all have on our red blood cells. That's not quite true. Some people have it on their red blood cells and some people don't. If we look at all of the rest of the world other than West Africa, the presence of Duffy antigen has a prevalence of approximately 99%. So if we tested all of our blood and we tested it for ABO and RH and then tested it for Duffy antigen, almost all of us would have Duffy antigen. It turns out that Vivax has to have Duffy antigen on the red blood cell or it cannot infect the red blood cell. Isn't that interesting? So Vivax can only really exist in places where Duffy antigen is common. Where is Duffy antigen not common? In West Africa. In West Africa, the people with Duffy antigen have all been wiped out. And so they do not have Duffy antigen, and they do not have Vivax malaria. Now the difference between Vivax and Ovale is, Ovale doesn't need Duffy antigen. It can get into red cells without Duffy antigen. So even though the two of them mimic each other, this is one major difference. Let's go on here. So we've already talked about falciparum getting at all red blood cells, Vivax and Ovale only reticulocytes, malaria, O blood cells. The incubation time is generally 2 weeks for all of them from the time of the mosquito bite. But we just learned about the ability for hypnozoites to stay in the liver without any symptoms and without dividing for months or sometimes years after leaving a malaria area and then causing malaria. If we look at the number of merozoites in the liver, falciparum wins the battle. They can produce 40,000 merozoites in a liver cell in the liver and release them all at the same time into the bloodstream. So it already has an advantage. In addition to all the other advantages we've talked about, it has an advantage in that it starts with a much bigger load of merozoites than with Vivax, Ovale, or malariae. Same thing a little bit with the red cell cycle. So the red cell cycle can have 8 to 24 merozoites per red cell. Some of the others much less. And then the periodicity. So usually once these get synchronized, the first three all recur in about 48-hour cycles and malaria in 72. Severity of attacks, it's really hard to tell. When I see someone with malaria, I can't tell clinically whether this is falciparum or Vivax or Ovale because they're all the same. They all start out like the flu. You have headaches and muscle aches, and then you get a shaking chill, and it's a bed-shaking chill. It shakes your whole body, and that will last for about 2 hours, and then for about another 6 to 12 hours, you'll have a high fever, and then that will break, and you'll develop a severe sweat, and then you'll get better. And you'll think, that wasn't so bad. Maybe I just had the influenza or something. But if that recurs then at 48 hours, then you begin to think, this could be malaria. Let's see. We've already talked about most all of the malaria. So 1 to 5% of people who get falciparum die. Very rare for anyone else. The latent infection is what we talk about with the hypnozoites. The chronic persistence is what we talked about with malaria. The large red blood cells we've already talked about Schiffner's dots that we've talked about, some of the other differences. Let's go on to diagnosis. So clinically, if you're in a malaria area, or if you just came from a malaria and you develop chills, fever, sweats, headache, and muscle aches, malaria has to be the top of the list. Most of the people in the world diagnose this by taking a drop of blood and putting it on a slide and then hemolyzing the red blood cells and just looking for the malaria organisms. So that's a pretty sensitive way to make this, make the diagnosis, and it's very inexpensive. All you need is a microscope and somebody that's experienced in looking for these malaria organisms, and that's how most of malaria is diagnosed now. There are other ways to do it. You can look at a thin smear. So the smears that we showed you today were all thin smears. So there you can look at, so it has some advantage. You can do it much faster than the other. You can do it a couple of different stains. You can look at the red cell morphology. So if you see large or small red cells, that may help you tell which malaria that you're looking at. The sensitivity is less because you don't have as many organisms on a thin smear as you have on a thick smear, but you're better able to determine whether it's falciparum or vivax or ovale or malariae on a thin smear. So that's a helpful way to look at this also. One of the most sensitive ways to make a diagnosis is with PCR testing. That's a very expensive way, but it's very sensitive and it's very specific, and it will pick up mixed infections. So an advantage to it, but it's so expensive and so high tech, it's not used except usually in research labs. Recently there's a new rapid test that's almost like a pregnancy test. You put a drop of blood on a piece of filter paper, you put 2 drops of developer on it, it migrates up the filter paper, and if it's falciparum malaria, you'll have two stripes, and if it's all other malaria, you'll have 1 stripe, and you can tell within about 10 minutes how to do this. This then is becoming the method of choice, because then you don't even need a microscope. All you need is a drop of blood and someone that can read it. It looks at 2 different things, an antigen and a histidine-rich protein antigen and a LDH antigen. And this is sensitive, it's simple, it's not very expensive, and many countries now are using this. And we use that here in our laboratory. When I see someone, I order this test because I can get that back usually within an hour to 2 hours. So prevention, vaccination. We have worked on a vaccine for malaria for years and years, and nothing has ever worked. We have a vaccine now that's being tried out, and we have friends in Ghana who are researchers in this area, and it works a little bit. So maybe a 50% chance of working over 6 months. Not a vaccine like we'd like to have. We'd like to have one that's absolutely preventive and give you lifetime immunity. This is not that vaccine, but it's the best we've ever done, and we're hopeful that vaccination may be a useful tool in eradicating this disease. So what do? We screen housing in Ghana, in the little villages that we showed you early. Almost impossible to put screens on. There are too many places in the house the mosquitoes can get in. So if you can't get screens on the windows, then mosquito netting over the beds. And we have an advantage now in that there's an insecticide we can spray these bed nets with that actually will kill mosquitoes. And so the bed nets are much more effective than when we used them in the past. So bed nets are a huge a part of our armamentarium to get rid of this organism. We can also use clothing and treat it with the same thing. So when I go to Ghana, I spray my clothing with a chemical called permethrin, and that helps protect me. We can use DEET on our skin to repel mosquitoes. And so that's the way we try and decrease the risk to us as we go into mosquito areas. We can also take medication. There are only very few places in the world now where chloroquine works, but there are at least 3 other good medications that we can take to try and prevent. Almost all of these, if you remember back with regards to falciparum malaria, all of these are focused on falciparum malaria. They don't prevent Vivax and Ovale malaria very well because they don't kill the organism in the liver, only once it gets into the red blood cells. Treatment-wise, there's still some places we can use chloroquine, but the biggest advance in treatment is a new medicine called artesunate lumefantrine. It's 2 medications. Artesunate is from an herbal medication used in China that has the ability to kill malaria better and faster than anything we've ever had. It is the medication that actually can kill some of these marginated red cells or infected red cells that are in our circulation. They do that better than any of the others. So the treatment of choice worldwide now is artesunate lumefantrine. And it's available also here in Salt Lake City. But there's some others. Tovapronol, mefloquine. If these people are so sick or unconscious, we can use artesunate IV, or we still use quinine. Or nowadays we use another thing called quinidine. If they're unconscious and we need to use IV medication, there's some IV medication. And then you remember the hypnozoites in the liver that may hide out for months or years. The only medicine that kills them effectively is primaquine. And so we use that when we find that, those problems. This is just a summary of that with regards to the agent, whether it's used for prevention, whether it's for treatment, and whether it can be used in pregnancy. Oops. And then finally, if we just look at the medications, this differentiates them just a little bit, talks a little bit about their toxicity. Again, the World Health drug of choice is the artesunate with the lumefantrine, and that then has a better chance of success than any of the other medications. All right, I think that's it. Any questions?